Visual field testing produces a clinical map of a patient's vision, highlighting exact areas of blindness across their peripheral sight. For a clinician, the challenge lies in the volume of distinct visual deficit patterns that can manifest from a single neural pathway. Medical education often relies on matching games, asking students to memorize abstract black and white shapes. Under the pressure of a clinical environment, rote memorization degrades. The visual pathway follows a continuous, highly structured geometric logic from the retina all the way to the primary visual cortex. By analyzing the schematic of the optic pathway next to a perimetry map, we can bypass memorization entirely. If you isolate the direction of the blindness on the map, you can locate the physical lesion using a simple vector heuristic. Applying this directional logic grounds perimetry results in physical anatomy, making localization a matter of structural deduction. Standard perimetry maps represent the left and right eyes as two circles. White areas show where vision is intact, and black areas indicate regions of blindness. The heuristic requires one specific mechanical step. You take the perimetry map and draw a high-contrast directional arrow strictly within the black, blind regions, pointing toward the outer edges of the deficit. The direction this arrow points serves as a localized vector. It represents the exact severed fiber pathways along the anatomical route. When examining a defect, it is easy to get distracted by its overall shape. To establish your primary anatomical location, the shape is irrelevant. Only the direction of the arrow matters. Translating abstract blind spots into discrete directional arrows provides the objective data required to navigate the anatomical map of the brain. This split screen tracks physical lesions on the left against their resulting perimetry vectors on the right. We start with the pre-chiasmal rule. Any lesion anterior to the optic chiasm intercepts the visual signal before it has a chance to cross over, meaning the damage affects only the corresponding eye. Severing the right optic nerve results in complete blindness in that single eye, rendering the entire right perimetry circle black. Moving posteriorly, the fibers reach the optic chiasm. Here, the nasal fibers from both retinas cross the midline. This intersection makes them highly vulnerable to central lesions, such as a pituitary adenoma pressing on the chiasm. Compressing these crossing fibers yields bitemporal hemianopsia, which is the specific loss of the outer temporal visual fields in both eyes. Applying the vector heuristic to this map, we draw our arrows in the blind outer halves. The left eye's arrow points left, the right eye's arrow points right. These opposing outward-pointing arrows visually form an X. This provides a definitive, instant diagnostic match for the anatomical X shape of the optic chiasm itself. Continuing posteriorly, we move behind the chiasm and enter the optic tract. Once past the chiasm, the biological wiring sorts itself. Fibers carrying visual data from the corresponding halves of both retinas now travel tightly bundled together on the exact same side of the brain. If a lesion cuts the right optic tract, the patient loses the entire left half of the visual field in both eyes. Draw the vectors in the blind spots. Both arrows now point to the left. This is a homonymous defect. It occurs exclusively because of the post-chiasmal anatomical sorting of the visual fields. This establishes an absolute rule of localization. If your perimeter arrows point in the exact same direction, the lesion is unequivocally post-chiasmal. Every post-chiasmal lesion yields arrows pointing in the same direction. To isolate the exact site along the posterior pathway, you must examine the granularity. Looking at the posterior brain, notice the structural difference. The optic tract is a dense, singular bundle of nerves, but further back, the optic radiations splay out and separate as they travel toward the occipital lobe. Because the optic tract is densely packed, a single lesion here severs the entire bundle, wiping out the full half-field of vision to create a complete hemianopia. But because the optic radiations split into two distinct, physically separated pathways, localized lesions here yield smaller quarter-field defects, known as quadrantinopias. Because the eye's lens inverts light, information from the upper visual field is processed by the lower retina. These inferior fibers travel through the temporal lobe, a pathway known as Meyer's loop. A lesion here severs the pathway for the upper world, creating a superior quadrant defect. Conversely, data from the lower visual field hits the upper retina, sending fibers through the superior root of the parietal lobe. Interrupting this parietal pathway deletes the bottom quarter of the visual field. Combining same direction arrows with this quarter field granularity allows a clinician to pinpoint pathology to a specific cerebral lobe without complex imaging. We can now apply this strict geometric logic to a series of raw visual field results. Case 1. Total unilateral blindness in a single eye. The input is blocked before it can cross. This is a pre-chiasmal optic nerve lesion. Case 2. We draw divergent arrows in the blind spots, forming an X. The lesion sits precisely at the optic chiasm. Case 3. The arrows point in the same direction, meaning it is post-chiasmal. The defect covers the full half field, meaning the fibers are bundled. This is an optic tract lesion. Case 4. The arrows point in the same direction, but they are restricted to the upper quarter field. Separated fibers in the superior pathway mean this is a temporal optic radiation lesion. Case 5. Parallel arrows isolated to the lower quarter field. This maps directly to the inferior pathway, indicating a parietal optic radiation lesion. This sequence shows how clinical maps translate directly into anatomical locations by identifying the vector and the density of the deficit. The clinical workflow is strictly mechanical. Count the affected eyes. Draw the directional arrows in the blind zones, and check the spatial granularity of the field. Visual field defects are strict anatomical shadows cast by physical lesions along the neural pathway. By trading rote memorization for spatial deduction, clinicians can extract actionable geometric data and localize neurological damage right at the bedside.